so our session can be on time. So first speaker is Professor Kataria. He probably doesn't need any introduction. He is a MD in radiation oncology. I'm very sorry. Really apologize for that. Yeah, she is radiation oncology and at the center, and it's very well established. I'm not going to really talk about that because information is there in the booklet for further information because they are busy people. So thank you very much. I'm sorry.
We started having a dialogue with Dr. Geeta Krishnan about 2 years ago when he referred one of oral cancer patients to us who was very old and had a poor ejection fraction, and she could not be operated upon. And these patients, when we treat them in the oral cavity, develop very severe mucositis precluding their oral intake and losing weight. And because of the poor ejection fraction, she could not have been administered IV fluids. So we had a discussion and we started looking at, so I thought I'll first start with this part of the study which we've already clinically done and then go on to review a bit of the literature. So for us, the oral mucosa constitutes the epithelium, the basement membrane, the subepithelial structures, and the tumors are normally situated in the epithelial layer, and then they breach the basement membrane. When we give radiation and or chemotherapy, is that we target the tumor, but we break down all this epithelium and the subepithelial tissues to take away the cancer cells. And then the mucosa is at risk for developing bacterial infection and leads to mucositis, which clinically presents normal is grade 0. This is when the patient starts with, except for the tumor which is there. And then they start developing erythema, mild symptoms when they cannot take spicy foods, but they can take normal diet, which goes on to grade 2 patchy ulcerations when they go on to soft or semi-solid diet. And then it comes to grade 3 when there is confluent mucositis and they cannot even take liquids. So that's a challenge, how to overcome this and take them through therapy, which is going to be very effective for overcoming their cancers. So we had a discussion with Dr. Geeta, and he introduced honey to us. Honey is a traditional Indian medicine which is effective mucosal healer, and it has an indirect part in the mechanism of wound healing. It directly interacts with the humoral processes of wound healing, and effect is as a result of non-peroxide bactericidal constituent methyl glycosol, and a slow release of hydrogen peroxide that helps prevent the bacterial action and prevents thereby the infections from setting in. And we did a little bit of literature review. There have been a couple of publications. This one was from Kolkata, in which the patients were administered 20 ml of honey 15 minutes before and 15 minutes after the treatment, and they were evaluated every week for the onset of radiation. And the patients who received honey had only 18% mucositis versus 41% for grade 3, and 4% versus 22% for grade 4 mucositis. The numbers are small, but they were seemingly very effective mode of treatment in comparison to whatever normally we treat as a standard of care for these patients. In another study from Iran, there also a significant reduction in mucositis among honey-receiving patients compared to controls was achieved. And in yet another study from Nepal, only 1 of 20 patients in the honey group developed intolerable mucositis. So these were very encouraging reports, and there is a study which is ongoing and also available on the web clinical trials curve, where the patients have been administered honey, Manuka honey. This is from Australia, Manuka honey, which is purified form of honey. And I think Dr. Geeta and his contemporaries would be able to tell you more about it. I am the end user, so I can say that I am starting to see the clinical effects which are beneficial for the patient. Coming to another salt, that's curcumin. And I was editor of a book recently in which I received a chapter in which we came across curcumin and its utility in the clinical patients with cancer. It's derived from turmeric, that is curcumin longa, and was isolated as early as 1815 by Virgil, and in 1870 the crystalline form was also identified. And this is the molecular formula. Besides curcumin, turmeric also contains other chemical constituents known as curcuminoids. And over 1,700 papers on curcumin have been published in the last 50 years, and these are the clinical profile where all across different clinical conditions, including chronic diseases like rheumatoid arthritis, multiple sclerosis, Alzheimer's, even HIV, wound healing, it has a huge broad spectrum therapeutic utility. And it has also been shown to reduce and suppress the transformation, proliferation, and metastasis of tumors by regulating various transcription factors, growth factors, inflammatory cytokines, protein kinases, and other enzymes. And it suppresses the growth of several tumor cell lines, including drug-resistant cell lines, by the expression of cyclin D1, and also activating caspase 8, which leads to sequential release of mitochondrial cytochrome C and activation of the caspases, which lead to the activation of poly-ADP ribose and apoptosis of tumor cells. So these are the basic mechanisms where curcumin has been found to be effective and working in the cell lines. And also there have been studies which suggest that curcumin has a radioprotective element or a property, and how it provides radioprotection is not yet fully understood. However, studies indicate that it can inhibit radiation-induced damage of specific proteins, and the activity of superoxide dismutase and glutathione peroxidase in the liver, which is increased by radiation, is reduced significantly by curcumin. So although Dr. Geeta calls it as an anti-inflammatory, we call it as a radioprotective property. And it also regulates the tumor suppressor pathways, triggering the mitochondrial mediated death in tumor tissue, thereby increasing the death of cancer cells. So here we call it as a radiation sensitizer. And in addition, it also works on the blood supply or the angiogenesis, thereby preventing metastasis. It has been shown that curcumin downregulates cigarette smoke-induced NF-kappa B activation in human lung epithelial cells. And for us, NF-kappa B plays an important role in inflammation, cell proliferation, apoptosis, and oncogenesis. So thereby, it suppresses the activation, and it is of particular interest in cancer. It has been shown to augment the cytotoxic effect of chemotherapeutic agents, which I believe Dr. Watt can elucidate better than I can. And there are studies which the investigators have reported the radiation sensitizing effects of curcumin in P53 mutant prostate cancer cell lines. So cells treated with curcumin in combination with radiation show a significant enhancement of radiation-induced clonogenic inhibition and apoptosis. So this is a cell with all its complex milieu, and we can see the upregulation of certain pathways and downregulation of certain other pathways in the cell, in the nucleosome, as well as in the cytoplasm. Cancer actually is an abnormal cell where a mutated or a damaged oncogene autoregulates the cell to produce abnormal cells, and it can affect different cells in the body and can produce a different gamut of diseases causing cancer. How do we come in here? Radiation is a very potent inhibitor of cancers because it produces a denaturation of the double strand of DNA helix of the tumor, and also rapidly dividing cells in the body. So the challenge for us is to treat the cancer but protect the normal tissues. Thereby we act, or we give the radiation based upon the tolerances of the normal tissues. How to escalate the dose, which is tumoricidal, is the challenge for us in the clinic. And radiation can knock out the double strand of this DNA helix by a direct effect if it is high energy, or if it is high density producing ionization, or by denaturation of the water molecule and production of nascent oxygen, which is known as the indirect effect. Garcinol, besides curcumin, is a natural histone acetylase transferase inhibitor. And garcinol is prepared from Garcinia indica, a fruit wren locally known as kokum, and grows on the western Ghats of India. It's widely used as a spice in culinary and as medicine in pharmaceuticals. This is a study published in Journal of Biological Chemistry in 2004 by Karanam Balasubramaniam, that polyisoprenylated benzophenone, that is garcinol, a natural histone acetyl transferase inhibitor, represses chromatin transcription and alters the global gene expression. And this is where we see that in case the cells were untreated, there is no apoptosis, but when 50 micrograms of garcinol treatment was given, the apoptotic pathways are perpetuated and the tumors start undergoing apoptotic process. And when the dose is increased, you can start seeing that multiple cells are undergoing apoptosis. And this is where both curcumin and garcinol work. That is, they work on the histones which are in the chromatin along with the DNA double-strand breaks. When radiation produces double-strand breaks, there is an automatic pathway to start repairing these double-strand breaks. And that is how the cell is becoming immortal and continuing to perpetuate the cancer. If we can block this pathway of double-strand break repair by hitting the histones which are aiding from the chromatin, the enzymatic modification to repair the pathway and get the cancer cell alive again, that is where garcinol and curcumin work. And this is the pictorial cartoon showing you all the various incompatible DNA, how it works and where the changes are occurring. I do not think I have an expertise to elaborate upon that, but from the literature we can see that basic work has already been done and in a scientific manner to prove that these two molecules work to aid the cancer control. So what are these histone acetylase transferase inhibitors that suppress the non-homologous end joining in human cells? One is curcumin, molecular weight, given here. It targets the CBP and P300 molecule, anacardic acid, and garcinol. So garcinol and curcumin I'll be talking about. Anacardic acid, I could not get much of the literature. And this is a study which we've already started seeing in our clinical journals now, published in the International Journal of Radiation Oncology, Biology, and Physics in 2009, where the curcumin was used to sensitize the colorectal cells by suppressing the constitutive and inducible NF-kappa B activity. And we see here the cell survival curves when we add on curcumin to the radiation dose, that at the same dose the effect of cell kill is increased. And here is a study by Mao Li in which they show that curcumin, which we've always been believing as a dietary component, that it has anti-cancer, chemosensitization, and radiosensitization effects, and that effect is mediated by downregulating the MDM2 oncogene through the PI3K and mTOR ETS2 pathway. And we can see here that in a cell growth assay, if the controls are continuing to grow, the addition of gemcitabine to curcumin and radiation to curcumin produces a sustained growth delay. Both the curves are showing very good growth delay even after 30 days of cell growth. And I had alluded to this study by Chendil et al. Earlier in my slides, Damodar and Chendil, and there they have shown that curcumin confers radiation sensitizing effect on the prostate cancer cell lines. And here we can see that the prostate cancer cell lines, along with radiation and curcumin, have continued to show a decrease in the growth of the cell lines even at 72 hours. So these are lab-controlled studies which are showing that there is a scientific evidence towards what we are discussing here today. And this is a study, again, by Karanam Balasubramaniam's group in 2004, where curcumin was shown to be a protein-specific inhibitor for P300 and CREB, that is the histone acetylase transferase, and the chromatin molecule downregulation, which I showed you earlier in the cartoon up there. And this is the acetyl-CoA and the histone inhibition by the addition of various concentrations of curcumin. And again, the apoptotic pathway being placed in action by addition of various concentrations of curcumin. Even it has been shown to have a potential radiation enhancer effect in head and neck cancer, and this is a study published in an international journal, the Laryngoscope. So just to briefly come down that it's been used, curcumin, anacardic acid, and garcinol in squamous cell carcinoma cell lines, prostate cancer, HeLa cells, which are the original cells in the cell lines where most of the lab work is done for cancers. It's been shown to have an inhibitory activity against rectal cancer, pancreatic cancer, colorectal, even in healthy volunteers. In obesity, this is another clinical use where I think we can have a debate. Coming to the fourth molecule, that is aloe vera, which is a succulent plant species and has been used in the herbal medicine since 1st century AD. Its leaves contain phytochemicals such as acetylated mannans, polymannans, anthraquinone, C-glycosides, and thrones and various lectins. And it has an evidence for cosmetic and therapeutic effectiveness, which is limited, but at present we do not have any direct evidence. It's seemingly contradictory. Maybe we haven't yet been able to elucidate the pathways where it can be used in the clinic, but maybe some of you know about the cancers that can be helped with. We have certain preparations, proprietary preparations, which contain aloe vera, and they say that it helps the radiation dermatitis. RadiaGuard is one of those proprietary preparations, which we haven't found very useful, but it's being marketed and used by some of the patients. The incidence of complementary and alternative medicine, as the botanicals were earlier known as, in 1998, Dr. Kelliot from Memorial Sloan Kettering said that patients, up to 64% of the patients, would use different kinds of complementary alternative medicines besides the standard of care for cancer care. And a common false belief was at that time that if it's natural, it must be safe. But now we are coming to a point where we can scientifically look at what is the molecule, what is the active ingredient, how to isolate it, and then use for patients without causing the side effects, which may be there in the pure form without having the separation of the active molecule. To conclude, ladies and gentlemen, all science is magic till we know how it works. And I would like to reiterate that what we used to call as complementary or alternative medicine is actually science and can work hand in hand with whatever we are doing at present. Science is a systematic body of knowledge of processes and their actions in the natural phenomena, which may have the label of natural phenomenon till we understand their basics. Thank you for your patient hearing.
Example, there are many, many examples of this thing. And I think the purpose of this meeting is here to find out what to do next. So both of the examples you showed, Manuka honey, I don't know why he went to Australia. We have in India.
He didn't go to Australia. We've been requesting him to get it from Dr. Ram's university.
Honey is going to be a very complicated case because of every honey is different. It depends where the region is coming. So making a medical preparation same for everybody is going to be challenging.
It's not only the challenge that we use honey. Dr. Geeta also has his reservations that honey is constipating because of his Ayurvedic, repository of knowledge that he has. So he tries to modify. For us, we do not know then how the other things that he's adding work. So it becomes very complicated for us at that time.
Any questions from the audience? Yes.
Any work that has been done on angiogenesis for any of these botanicals?
As I said in one of my slides, that curcumin has been shown to block the angiogenesis. It shuts down the vascular supply to the tumor. So there are papers on that, yes.
You all have not done anything.
Sorry?
You all have not worked on that.
We have not yet started working on that, no. But if we work, we will not be doing the work from here. We will be probably working with the universities where the basic scientists are there, and they can be working on these molecules to start looking at that, and also developing the cell models and the animal models where we can show the results directly. Like the chairperson said here, that the purpose of this meeting is that we bring forth our collaborative effort to see from where we are, whatever the basic work has been done, how it can be translated to the bedside of the patient. And there is a long pathway from preclinical to clinical studies before we can say that yes, it works.
Since you're talking about curcumin, I will take the opportunity to tell you how things get worse. Have you ever seen Indian curry that curcumin precipitated in it? Anybody has seen Indian curry that curcumin is? Yellow stuff is precipitated? Curcumin alone is so difficult, it's not bioavailable. They can't make it pure compound. If they use a traditional preparation, bioavailability is not a problem, because we consume all the time and never precipitate curcumin. But taking it as a single molecule, which was very well defined, everybody made their life difficult. Now they're going to nanotechnology, this formulation and that formulation. But if they put some oil in it and fry it, they get everything. And people consume anything. Sometimes we have to come back to our roots and see what makes sense, not what science says.
You know, I think there is a very good example also from the Mediterranean diet, which is now being propounded as protector for atherosclerosis. Actually, what Mediterranean diet contains is olive oil and tomatoes. And the substance that is produced there is lycopene, which we say is, you know, cancer protectant or an antioxidant, very potent antioxidant. So similarly, your observation on curcumin being used as a culinary constituent in our spices and in our daily use, maybe that is what is protecting most of us. We don't know.
Anyway, thank you very much.
Thank you.
That was very interesting. Now we have the next speaker. Dr. Wade was Dr. Ashok.